Welcome to the webinar on Neonatal Hypoglycemia, a look at the medical and legal issues. This is the second in a series of Connect Experts webinars, blending both the medical legal audience and the medical and legal issues, all based on my personal belief that the sharing of knowledge can positively impact both professions, healthcare and law. Our attendees today include a mix of doctors and nurses and plaintiff and defense lawyers from across the country, and I'm so glad that every single one of you are here. So welcome, and thanks for showing up. This is going to be a great webinar today. Earlier this week, everyone should have received a copy of the Canadian Pediatric Society position statement titled The Screening and Management of Newborns at Risk for Low Blood Glucose. Along with that, there was an algorithm sheet and a case study with some facts of a hypoglycemia case, which we're going to discuss today. If you didn't receive that, it's available in a chat box. I believe there's a link available in the chat box, which you can download right away. So please help yourself. Today's webinar will be 90-ish minutes long, starting with a brief overview of the case study. Followed by a presentation of the guidelines by Dr. Michael Narvey, who's one of the principal authors. Following that, we'll take a look at the legal issues by lawyer Joe Miller. And then Dr. Narvey and I will, somewhere in there, both insert our expert opinions on how the medical and nursing care was managed in the case study. Then at the end, we'll leave some time for Q&A and wrap things up. This is going to be a great webinar. I'm very, very excited to be here today. A recorded version of the webinar will be available by the middle of next week, approximately May 20th, for those of you who have either purchased a copy or want to view a second copy. And that will be available ongoing for the next couple of years, probably until this guideline gets changed or updated, however long that happens to take. A couple of other small comments before we start. Right up front, apologies for any difficulties with the Zoom meeting. As magic as they are, things happen. It's not without challenges, so just forgive, please, right up front. At any time during the webinar, please submit your questions in the chat box or using the Q&A button, which is found near the middle bottom of your screen. We'll address questions when we can throughout the webinar, but certainly at the end. If you have any audio or video trouble, we've got some tech support standing by, so send us a message if you're having trouble and we'll try to get you sorted. Everyone in attendance today should be able to claim continuing education credits from their professional associations. If you need support or assistance doing so, get in touch with me, and we're always here and happy to support professional development. I see people are still joining over the last couple of minutes, and to all of you, welcome. I'm Chris Rokosh, and this is a Neonatal Hypoglycemia webinar. We're really, really glad you're here with us, so thanks for joining. Now, a quick intro of today's presenters. Dr. Michael Narvey is the section head of neonatology at the Winnipeg Health Sciences Centre. He's the committee chair of the Canadian Pediatric Society Fetus and Newborn Committee. He's also the medical director of the Child Health Transport Team, the associate professor at the Department of Pediatrics and Child Health, investigator of the Children's Hospital Research Institute of Manitoba. He's also one of the principal authors of the guideline, which we're going to discuss today, the screening and management of newborns at risk for low blood glucose. He's a busy guy and a fabulous teacher, and we're really lucky to have him here with us today. Our second speaker, lawyer Joe Miller, of Weir Bowen LLP in Edmonton, represents plaintiffs in medical malpractice cases. Joe has litigated more malpractice claims than any other plaintiff's lawyer in Alberta. He's appeared before Alberta's highest courts. He's conducted seminars on malpractice issues for lawyers and doctors and nurses, and he's recognized as one of the best lawyers in Canada. In 2010, he was appointed Queen's Counsel. In 2011, he received the Gary J. Biggs Champion of Justice Award and invited to join the Litigation Council of America, whose membership is limited to less than 0.5% of all lawyers. He's very well known and well respected as a lawyer, and we're also lucky to have him here with us today. So welcome to both of you. We'll get you teed up to speak in just a couple of minutes. I'm going to start off today with a brief overview of the case study so that you can keep the facts in mind as Dr. Narvey speaks. And this will allow you, I hope, to identify potential risk factors, potential issues with the medical and the nursing care, take a look at the risk management and consider some of the issues potentially surrounding causation. So here goes. This is a brief rundown of the case study, which you've all received. On March 16, 2019, the infant Amelia LeBlanc was born to a 36-year-old woman at 42 weeks gestation in her first pregnancy. Obstetrical ultrasounds were performed at 7, 20, and 31 weeks, and all normal. The pregnancy itself was overall normal. A complication at 36 weeks is that the hemoglobin was slightly decreased. Weight gain was 32 pounds, GBS was negative, diabetic screening was negative. The one complicating factor is that fundal height measurements were consistently less than gestational age after 38 weeks gestation. The last documented measurement in the medical record was that the symphysis fundal height was 34 centimeters 1 day before delivery at 42 weeks gestation. On March 16th, 42 weeks gestation exactly, at 10:45 in the morning, the mother presented at the hospital with contractions. The cervix at that time was 2 to 3 centimeters dilated and 50% effaced. The amniotic membranes were intact. Fetal monitoring at that point in labor revealed a baseline of 144 beats per minute with decelerations reaching 110 beats per minute. Overall decreased variability continued and was complicated by variable decelerations throughout. When the amniotic membranes were ruptured at 12:20 p.m., there was only a small amount of fluid, and it was heavily meconium stained. Consultation occurred with an obstetrician. At approximately 3 p.m., a fetal scalp blood sampling was done, which showed a normal pH of 7.28. At 3:40, labor was augmented with oxytocin, but within 15 minutes, due to increasing variable and late decelerations, the mother was prepared for C-section. The indications for surgery were listed as post-maturity, meconium-stained fluid, suspected small for gestational age, and atypical and abnormal fetal heart rate findings. At 5:30 p.m., a live female infant was delivered by C-section. There was a significant amount of meconium in the amniotic fluid, and it was noted that the umbilical cord was presenting right beside the fetal head. The placenta was very small. Apgars were 6 and 9 at 1 and 5 minutes. Umbilical cord gases were basically normal, essentially normal. Birth weight was 2835 grams, or 6 pounds, 2.5 ounces, which is approximately the 5th percentile. Birth length was 55 centimeters, which puts the baby at approximately the 90th percentile. Head circumference was 34 centimeters, which is at the 50th percentile. The infant's gestational age was simply described as post-mature. The infant breastfed very well in the recovery room, and again 4 hours later. This takes us now to March 17th, the first day of life, and I'm going to focus on the feeding and the infant's behavior in the first 2 days of life. In the first 12 hours, the infant was put to the breast of day 1, first 12 hours of day 1. The infant was put to the breast 4 times at periods of 2 to 4 hours apart. At first, her suck was noted to be strong, but gradually decreased throughout the day to where the nurses said she required assistance with feeding, and then they said she made an effort. She peed once and passed meconium 3 times. Color and behavior were described as normal. In the last 12 hours of day 1, the infant was put to the breast 4 times. There was no comment in the medical record on effort, suck, or latch, but it was again noted that she required assistance. By 6 p.m., just over 24 hours of age, she was being supplemented with formula and received a total of 42 mils of formula on this evening. She peed twice and passed meconium twice. Vital signs, tone, and behavior were reported as normal. At the end of the day, her cry was described as quiet, her color was slightly jaundiced, and there was a weight loss of 150 grams since birth. March 18th, the second day of life, in the first 12 hours, the infant was put to the breast a total of 5 times. She was noted to have fed well once, not fed at all once, and there was no comment on the other 3 feeds. She was supplemented with 33 mils of formula. There was 1 wet diaper, 4 mech diapers. There's a nearly 7-hour period between 10 a.m. and 4:45 p.m. without infant formula supplementation and without documentation confirming any adequate breastfeeding. Over the next 12 hours, the infant was placed at the breast twice. Once she didn't feed, the second time there was no comment on her effort. She was supplemented with a total of 35 mils of formula in this 12 hours. She was not put to the breast or supplemented with formula in the 5-hour period between 7 p.m. and midnight. Shortly after midnight on the 3rd day of life, the infant's color was described as pale and slightly jaundiced. Behavior was noted to be sleepy. She was put to the breast, and it simply said she required assistance with latching. No comment on the adequacy of this feed. Then at 1:10 a.m., the infant was found to be very pale with decreased tone. She was taken to the nursery to feed and described as a very poor feeder. After being placed in a crib, the baby remained pale and turned blue despite the administration of oxygen. A pediatrician was called and attended within moments. Rectal temperature was decreased to 35.7. Birth weight at this time was noted to be 2,600 grams, a loss of 235 grams since birth. Blood glucose at this time was critically low at 1.0. She was admitted to the NICU with a diagnosis of cyanosis, dehydration, and hypoglycemia. Her behavior was described as jittery, lethargic. She was cold to the touch and had low body tone. At 2:15 a.m., the infant was given IV dextrose and water. By 3:30 a.m., there was seizure activity. By 3:55 a.m., blood glucose had returned to normal, but seizure activity continued. Despite the advances in neonatal care, hypoglycemia remains one of the most common newborn conditions. With all of that in mind, please now welcome Dr. Michael Narvey as he walks us through the Canadian Pediatric Society position statement, the screening and management of newborns at risk for low blood glucose. Welcome, Dr. Narvey.
Thank you for having me, Chris. You can hear me okay?
Yes, we can.
Okay, I will need screen sharing allowed, and then I can begin. Thank you. Okay, you can see the slides then?
Yes, looks great, looks great.
Okay, all right, I'll begin then. Thank you for the introduction, Chris. Looking forward to spending the next 75 minutes or so chatting about something that over the last few years has become near and dear to my heart. So we're going to be talking about hypoglycemia in the newborn, and I am going to show you or walk you through a little bit of how the statement came into development, and something that I think will be very important for you to see are, some of the pitfalls as you're trying to develop statements, because I know that the statements are often used in many centers almost verbatim when developing guidelines. But there are challenges to developing these, and we'll go through some of the evidence that went into them. So we'll explore the definition and treatment options for low blood glucose in the newborn. As I mentioned, we'll share the story of our statement development. And then I'll conclude with, just going through the statement a little bit, specifically with respect to, what directions would we have you go in if you're a healthcare practitioner caring for these types of babies. So to begin with, as an introduction, I think it's important to distinguish physiologic changes from pathologic changes. We know that when the cord is clamped after birth, the steady supply of glucose is interrupted. Babies will experience a transient fall in their blood glucose. By an hour of age, the 5th percentile is about 1.8 millimoles per liter in otherwise healthy term infants. But over the first 48 to 72 hours, that blood sugar should start to come back. Persistent neonatal hypoglycemia, though, is another entity in which there are aberrations in the endocrine axis, which lead to problems with persistent hypoglycemia beyond that first 48 to 72 hours. Certainly in that transition period between 48 to 72 hours, one is never certain whether you're dealing with something that is still transitional or whether you're dealing with something that is persistent. And that, as we'll talk about, goes into some of the recommendations that we have. As I think you probably picked up from the case, prompt recognition of true persistent neonatal hypoglycemia is important. And the reason we say it's important is because we're trying to prevent negative effects on development, which we'll talk about in a few minutes. Something that I think you'll appreciate by the end of this talk is that the definition of hypoglycemia in terms of cutoff and picking absolute numbers is very controversial. One of the reasons for controversy is the difference between clinical manifestations and physiologic responses. So what I mean by that is, if you have a baby with a blood glucose, let's say of 2.5, who is pink, normal tone, reacting otherwise normally at the breast or bottle, feeding well, we would say by a cutoff number that baby has hypoglycemia, where even though there's no symptoms because it's a number. On the other hand, we might say a baby who has a sugar of 2.5 and is lethargic, won't feed, based on the clinical manifestations, has significant hypoglycemia, whereas other places would say, no, that should be under 2.2. And alternatively, there's also the physiologic response. When you measure hormone levels, the counter-regulatory hormones, do you see a response? And as you'll soon hear, that was one of the arguments made by the Pediatric Endocrine Society when they released their guidelines in 2015. When it comes to developmental delay, which I know that there are many attorneys listening today, and that's one of the questions that always comes up is, is it the level? So is it 2.6? Is it 2.2? Is it 2.0? 3.3? What level is it that might cause developmental delay? Another question that comes up, is it really about the duration? Is it not just a single level, but is it multiple insults over multiple days or multiple hours that leads to developmental delay? Third thing is, what disease? Is it possible that babies who go on to develop hypoglycemia develop abnormally in utero so that they are intrinsically abnormal to begin with? Or is it the repeated insults after birth of the disease itself? Trying to answer a little bit, you have to go back over 30 years. Alan Lucas, who's done a tremendous amount of work in the area of neonatal nutrition, published a study in the British Medical Journal back in 1988, in which he looked at premature infants who were small. So these are not term infants, but these are preterm infants, and that's an important distinction. What he found, and this number you'll hear many times over, what he found was when he looked at where the risk of developmental delay was, it was when the babies had blood glucoses less than 2.6 millimoles per liter. And what he also found was that there was a statistically significant increase in risk of developmental disability when you had greater than or equal to 5 episodes of hypoglycemia in the first 2 months. Now, this is a level less than 2.6, could contribute to developmental delay. Now, this again is in a preterm population, so we have to be careful that we don't extrapolate this to all babies, but this is where one of the numbers, that 2.6, comes from. Interestingly, when you jump to 2015, almost 30 years later, in a follow-up of babies who were all born over 35 weeks gestation who participated in a glucose gel trial, what they looked at was in the glucose gel trials, these kids, and this was by Debbie Harris and others, these kids were treated based on having a goal of blood glucose over the first 7 days of greater than 2.6. In the trial, they were using continuous glucose monitoring, a little more on that later. And interestingly, when you put a continuous glucose monitor, and you may know from friends of yours, perhaps, who have diabetes, who have one of these, you implant it in the subcutaneous tissue, and it can tell you second to second what the blood glucose is. About a quarter of the babies who were actually hypoglycemic based on continuous glucose monitoring. But when you test intermittently every 2 to 4 hours, let's say, you might have missed the fact that the blood glucose was low. There was no increased risk, even with severe hypoglycemia, there was no increased risk of developmental delay. So what that questions there is whether you are hypoglycemic or not, as long as you're trying to maintain that sugar over 2.6, even if you have, contrary to the Lucas study, they found even if you had greater than or equal to 3 episodes, you still didn't have an increased risk of developmental delay. But then along comes this study, and this study, I think, as I shared with Joe prior to this meeting, I think that this study, this is a wonderful study, and I thank the Swedes for the work that they do. For those of you who don't know, the Swedish, there's a Swedish registry which tracks all births in Sweden, and so they can look at hundreds of thousands of babies. And you can see in this study, what they looked at was trying to answer a question which I'm sure is near and dear to everyone's heart here, which was, does moderate neonatal hypoglycemia lead to adverse neurological development at 2 to 6 years? They looked at about 100,000 babies, and what they looked at was defining, which is a bit different than what we define here in Canada, but they used a definition of hypoglycemia as less than or equal to 2.2 millimoles per liter. Generally, they tried to keep the blood glucose at 2.8 or more. And what they found was that any neurological or neurodevelopmental outcome in the presence of hypoglycemia, when they adjusted after logistic regression for other risk factors, they found about a 1.5 times risk of having developmental delay with hypoglycemia. And this, what's great about this study is that by it being a population study, you're getting a massive sample. So any developmental delay was about 2.5 times the risk with hypoglycemia compared to babies that didn't have hypoglycemia. Motor was about twice. Cognitive specifically was about 3 times. Interestingly, autism, tics, and epileptic seizures, when you look at the confidence interval on the adjusted numbers on the far right, autism, tics, and epileptic seizures were not at increased risk with hypoglycemia. So the authors further decided to look and dig down into timing of hypoglycemia. So they didn't look so much at number of episodes, but they tried to look at, is being hypoglycemic early worse or better than being hypoglycemic late? And what they actually found was that any neurological or neurodevelopmental outcome was statistically increased in the presence of early hypoglycemia. Basically, you had about a 2-fold risk of having neurodevelopmental delay if in the first 6 hours of life you had hypoglycemia, versus late, where there was not an increased risk because the 95% confidence interval crossed 1. Similarly, though, any developmental delay, any developmental delay and cognitive delay were increased statistically by the early hypoglycemia. So putting it all together, you could say multiple episodes, 5 or more in premature infants can lead to neurological injury. Early untreated hypoglycemia can lead to neurological injury. And the final question is one number good for all? And to answer that question, and this is just, this is really thought-provoking more than being able to prove anything, but I mentioned to you in the McKinley study that there was no difference between hypoglycemic infants who were targeted of 2.6 or more for 7 days versus those who were not. But when you dig down and you look at Debbie Harris's publication, looking at the outcome 2 years after dextrose gel treatment, this figure was in the journal, and I thought it was very interesting because what it showed you was, it's true, there is no difference in the rate of neurosensory impairment at 38% in the dextrose gel group and 34% in the placebo group. But my question that I ask is, why is there any neurosensory impairment to that level in these babies? Out of 500 and some odd babies, about a third of them in both groups have neurosensory impairment. Now, 31% out of the 38% are mild, and 33% out of the 34% in the placebo group are mild. But this raises the question, is it that the threshold of 2.6 is appropriate for the first 7 days of life, which is what we generally had always done. And for many of you that will have many of you that will have cases that you're dealing with involving hypoglycemia prior to 2019, as you would know, the recommendation from the CPS and the AAP was in that 2.6 to 2.5 range. So how do we define normal? I love this slide because it's by Marvin Kornblath from 1965. So 60 years ago, there was this quote: "Although an extensive literature exists, there is still disagreement over which levels of blood sugar are normal in the neonate and which are hypoglycemic or hyperglycemic." Well, believe it or not, we're still debating this 60 years later. But what he showed, and again, this was both in full-term neonates and in low birth weight infants, in preterm infants. But what he showed, and this is an important piece of information, is that following birth, if you measure cord glucose, at birth, the cord glucose is quite high. It would be in the range of what maternal should be. Maternal is going to be about a third to half higher than what the fetus glucose would be. But after that, you lose, in the first 12 hours, you lose your blood sugar as you're burning it for energy. And what happens is, for the first 1 to 2 days, in a preterm infant, their blood sugars hover around 2.6. The preterm and the term infant, they hover a little bit higher. But generally, by day 2 to 3, you see this rise in the term infants to the 3.3, roughly, 3.3 and above millimoles per liter. And this actually then influenced what we recommended in the new CPS statement. More recently, this actually just came out again, Debbie Harris and the group from New Zealand, published in August 2020, I thought a very interesting study because it looked at a modern cohort of healthy term infants in the first 5 days. So these were babies that are not at risk. These are not your infants of diabetic moms. These are not your preterms. These are not SGAs or LGAs. But these are babies who would be deemed not to be at risk and just wanted to see what is a normal blood sugar. They used continuous glucose monitoring. And what they did was they calibrated each of the continuous glucose monitors by ensuring that they checked point of care glucoses frequently up to 120 hours of age. Interestingly, what they found is, even though 60 years have gone by, if you look at what the blood sugars were in the plasma and the interstitial, and these are healthy term infants, in general, these blood sugars for the 50th percentile hovered around 3 for normal babies, but as low as the 10th percentile would be around that 2.6 in the first 2 days of life, and then you could see they began to rise. Similarly, the interstitial glucoses were followed a similar pattern. So what we know, whether you're using Kornblath or whether you're using Harris, is that naturally sometime between 48 and 72 hours, normal babies experience a rise in blood sugar. So I point this out because the notion that we should keep the blood sugar target 2.6 and above, which we did for 30 to 40 years, may have been wrong. And so the new statement will reflect that. Interestingly, when you look at the study, the GLOW study, they compared the different groups, whether it was American Academy of Pediatrics, World Health, British Association, or Pediatric Endocrine. And drawing your attention to the Pediatric Endocrine Society, what you would see is even up to 48 to 72 hours, the number of infants with episodes of glucose concentrations below recommended thresholds for treatment, and these are in asymptomatic, non-at-risk babies, were significant. So the point is, hypoglycemia is common. And so it's so common, we all need to know how to treat it and treat it well. So on to the development of a statement. Armed with all of that previous information, we began the process of developing the statement back in 2016. As you'll notice, we didn't publish until 2019. I can't go through all the details of why that was, but I will say there were hundreds, if not thousands actually, of articles to review. My colleague and I, Dr. Seth Marks, an endocrinologist, went through all the articles, and we sent our first draft to the Fetus and Newborn Committee in fall of 2017. So you can imagine it took a long time. There were multiple rounds of review, as this we knew would be a very contentious issue, and we finally published in November of 2019. As part of the process, just so you know how these statements are developed, we did have external reviews by endocrinologists within Canada. The American Academy of Pediatrics has a liaison member on our committee, and the liaison, Dr. Cummings, took that statement to the Americans and had their input, and whether or not they thought there were any glaring omissions. Within the CPS, Community Pediatrics, had a review. Nutrition, I had to comment here. The Committee on Nutrition from the Canadian Pediatric Society sent me 13 pages of comments, which I had to wade through. And finally, the College of, the College of Physicians, Family Physicians, had a review, as did representatives from Canadian groups of family physicians. So this was a well-reviewed document. The document was heavily influenced by a document that I had already mentioned, recommendations from the Pediatric Endocrine Society for Evaluation and Management of Persistent Hypoglycemia in Neonates, Infants, and Children. I'm including this specifically because I think you'll be surprised by some things that came out of this. I don't want to disparage any of the authors. They're all very respected people. I know some of these people. Dr. Thornton and Dr. Stanley are definitely amongst the two most respected people in the hypoglycemia literature, and really were the the chief investigators, if you will, for coming up with these recommendations. The document was released 4 years prior to our statement. It was the first document to really suggest that at 48 to 72 hours we need to rethink our thresholds. They talked a lot about physiologic neuroendocrine responses, meaning we should be treating hypoglycemia not based on symptoms alone, but based on what the body is telling us. If you measure hormonal levels, are they rising in response to a certain sugar? They suggested using 2.8 before 48 hours and using 3.3 to 3.9 after 48 hours, which really was in keeping with Kornblath's work from 30 to 40 years ago. And importantly, they recommended a monitored fast required prior to discharge. At the time, so this is pre-2019, the CPS had no recommendation after 48 hours, but was at 2.6, less than 48. The AAP, as I mentioned, was close to 2.5. So the PES was a departure. Importantly, as I mentioned at the beginning, it can be very hard to give absolute numbers, but these are direct quotes from the papers from those years, the position statements. Neonatal hypoglycemia cannot be defined by a single value, which is what the CPS said. The AAP said current evidence does not support a specific concentration of glucose, and the PES said hypoglycemia cannot be defined as a specific plasma glucose concentration. This, of course, creates a lot of questions, I'm sure, in practitioners' minds. If you can't say that hypoglycemia is defined by a number, then how exactly can you suggest it? And really what they're getting at is it's more the trend. One-offs do not matter as much as what the trend is. However, I can tell you what happened locally was we adopted these changes at 48 to 72 hours, and some of my colleagues pushed back. They were scared about using higher thresholds would mean more admissions. And so my colleague and I, Dr. Marks, went through with a fine-tooth comb the PES statement, specifically the references that they used to make these recommendations of using 3.3 millimoles per liter as a cutoff. We had initially, and this is a good lesson, we had initially just taken the statement as written by the authorities on hypoglycemia in North America, but the review of the statement uncovered several problems. None of the quoted papers included neonates on the section that argued that we should be using higher thresholds. And the main argument for normal misstated 2 days instead of 2 years. So when they talked about what the normal glucose threshold should be, in the paper they said infants 2 days to 18 years, but it was actually taken from a book on diabetes. And when we looked up the book, the children that were used in that quote were actually 2 years to 18 years, not 2 days. The neuroglycopenic thresholds were also taken from a book on diabetes in children and were not pertaining to neonates. And surprisingly, they misquoted a reference indicating that neonates were more susceptible to injury, but when you pulled the reference, much like corn blasts showed that the preterm neonates in particular will be expected to function with lower blood sugars and are generally protected at these lower thresholds. The argument for using higher thresholds in neonates was based on that misquote that they are more susceptible, when in fact they are not. We reached out, actually, we wrote to Doctors Kornblath and Thornton and asked them a specific question. We pointed out these deficiencies. And their response was, we tried to avoid the numbers game of defining hypoglycemia by a specific number. But it just goes to show you that when you have these references, and I'm sure it's similar in law, always best to go to the original source and see whether the quotes are accurate. Having said all that, in November 2019, we finally released the Screening and Management of Newborns at Risk for Low Blood Glucose, which took almost 3 years to produce. Shockingly, 1 month after releasing the statement, I received a letter asking me to withdraw the statement. There was a threat of a letter that was going to be generated. I received a sample of the letter, which was to be signed by neonatologists across Canada, and I was told they would be all asking for withdrawal of the statement because the argument that they were making was that the results of the study showing that the number 2.6 was unnecessary were about to be released, and this would invalidate the statement and we would be unnecessarily poking babies. As you will know, the statement was never withdrawn. What the study that he was referring to, and I don't want to give away location, but what I will say is there was one center in Canada that has been using a threshold of under 2 as being abnormal for some time. I don't know if there's other centers, but there was one center that had been using under 2 for a long time. And what the study he was quoting was released in February 2020. And again, the devil's in the details, so important to look at it. This was called the HypoExit study, and you've probably heard of this, or if you haven't heard of it, you will, which was questioning the need to use these traditional treatment thresholds of 2.6 or whether under 2 was a better number to use. It was a randomized trial, which we like to see. Kids were randomized between 3 to 24 hours of age to either respond to under 2 or respond to under 2.6. The groups were all typical babies that we would consider to be at risk: late preterm infants, babies who are small for gestational age, babies who are large for gestational age, and infants of diabetic mothers. An important point about this study is they were looking here at moderate or modest. They were aiming for modest blood glucose, and none had an initial blood glucose of under 1.9, as they would have been classified as severe. So although you could drop below 2, they excluded any babies who had blood glucoses under 1.9. So really their target population were really mild to moderate hypoglycemics. What the study ultimately showed, and this is why this particular neonatologist got very excited initially, was that from table 2, which I realize is impossible to read on your screens, these are a whole bunch of different measures of neurodevelopmental outcome using the Bayley-3 scales at 18 months of age. And what they showed, and I'll just summarize it, is no difference. So no difference in the overall population, no difference in any of the subgroups, whether you had a low threshold or a traditional threshold. And so the argument that they made, or they tried to make, was that we have been needlessly poking babies who have blood sugars of 2.2, 2.3, 2.5, and following these babies when the neurodevelopmental outcome at 18 months is no different. Unfortunately, and the reason why this was never signed by any neonatologists in Canada, the study was so specific at excluding kids who had more significant hypoglycemia that really what this study proved was the following. When you look at one of the tables, once babies were randomized, so you had to have a sugar under 2.6 to get randomized. Once they were randomized, 57% never had in the intervention group, or sorry, the high threshold group, 57% never had another episode, whereas 47% never had another episode. And the number of hypoglycemic episodes these kids had at all were 70% in one group and 82% in the other group. So in other words, they changed the goalposts but they really didn't capture anyone with hypoglycemia. So that's why they probably didn't find any difference. And so the main points here are also, when you're doing a study, they were aiming to get a certain number of babies per group, and they didn't meet it. So if they didn't get the right number of babies that they needed to show a difference, you can't confidently say, as they didn't in the infant of diabetic mothers, if they didn't find a difference, it might just be that they didn't have enough numbers. Severe hypoglycemia was only found in 10% of the low threshold group and 5% in the high threshold group. And then finally, I like to apply the own child test. And when I asked around in my colleagues in different jurisdictions and asked them, what would you do? How comfortable would you be if you had a baby and or grandchild, and your baby or grandchild had a blood sugar of 2.3, which they would consider normal if you use it under 2.0 as the threshold. Would you be comfortable never checking that again? And the answer resoundingly, as you might expect, was no. Everyone would want to check it again. So I think 2.6 is probably a fair number in the first 48 to 72 hours. And the hypoexit study, in case you see it quoted, really, I think, missed the mark. When we look at infants that are at risk, that would be in table 1 of the document that you received, the position statement. I won't read them all out to you, but I will point out, I went through the first 4 that we talked about. Preterm infants are certainly at risk because they've been taken out of the womb at a time before they've had glycogen stored in the liver. Labetalol interferes with insulin after birth, and so any history of labetalol would be important to note. Late preterms who are increasingly being given antenatal steroids at 34, 35 weeks may have hypoglycemia afterwards. Perinatal asphyxia, in particular, where you have significant evidence that there's been an asphyxiated infant, again, they will burn through the glycogen in the liver and therefore are at risk of hypoglycemia. And then there's some rarer things, metabolic conditions, or Beckwith-Wiedemann syndrome, which is a condition in which you have enlargement of the pancreas and hyperinsulinism. When we talk about obtaining a sample, there's different ways of doing it. The point of care testing, it's very important to note that whole blood can be 10 to 20% lower than plasma. Point of care, this means can be have a difference of plus or minus 0.3 to 0.6 when your sugar is anywhere around 3. That becomes important in the recommendations from the CPS. We talked about continuous glucose monitoring. There are delays of anywhere from 5 to 10 minutes, depending on the monitor, comparing serum to interstitial glucose. However, I think that you're going to find, as the years go by, greater adoption of this, because in particular for infants of a diabetic mother who often are hypoglycemic due to hyperinsulinism for some time, their heels can get quite damaged. So having something that's implantable for a week certainly confers some advantages. So how should we screen at-risk infants after birth? Any baby who's demonstrating symptoms, we recommend to test immediately. This I put in bold because it is so important. Feed prior to the 2 hours. We recommend checking at 2 hours of age in asymptomatic infants, and if you're at risk and you don't feed, they are likely to be hypoglycemic. For infants of diabetic mothers, after 12 hours, if you've had blood sugars that are all greater than or equal to 2.6, you can stop testing. And in SGA babies and in premature infants, you can stop after 24 hours. This was the big change in the 2019 statement. After greater than or equal to 72 hours, we go to 3.3 millimoles per liter. You'll notice there's a difference, and this confuses people sometimes, a difference between the therapeutic goal and the investigation threshold. The reason for the difference is because, and we use 2.8 for investigation threshold. The reason, again, has to do with the point of care inaccuracy of 10 to 20%. If you have a baby, let's say, who has a blood sugar of 3.2 at 96 hours of age, that would appear to be hypoglycemic. But if you draw a lot of blood work, checking things like insulin and ketones and free fatty acids, growth hormone levels, which are all part of the workup for persistent hypoglycemia, and there's a 10 or 20% error, and the blood glucose comes back, the true from the lab comes back at 3.8. the endocrinologist will say, sorry, we can't actually interpret this data. You need to have a low sugar. So in order to ensure that you actually have a sugar that is going to be under 3.3 at 72 hours or longer, and then can actually make an analysis of the critical sample to figure out what the condition is that's affecting this infant, we have a different investigation threshold. As far as treatment goes, breastfeeding, skin-to-skin care, increasing volumes of fluid, all of these things have been shown to improve your baby's glucose concentration. Glucose gel has come on the scene since about 2013 and is used with increasing frequency across Canada. Glucose gel of note gives you 200 milligrams per kilogram of dextrose, which is the same as a D10W 2 milliliter per kilogram bolus. Sometimes we will change the frequency of feedings. It's important, I should mention, when you give glucose gel to give it with a feed. Sometimes we go to continuous feeds. Sometimes we'll go and increase the concentration of an IV once it's in place. And as far as some of our more fancy treatments, there are a number of treatments such as octreotide, growth hormone, diazoxide, hydrocortisone, and glucagon, which you can give for persistent hypoglycemia. As mentioned, dextrose gel, which it was designed for adults, but it does, with diabetes, it does give you that 200 milligrams per kilo. In 2013, Debbie Harris's group published the Sugar Baby study, which is, and I shared with you some of the follow-up from that. The goal in that study was to, the primary outcome was a reduction in the numbers of babies with blood glucoses under 2.6 after 2 treatments. What she found was that there was absolutely no difference in the number of babies admitted to the NICU, which is not surprising because these babies typically, when you look at risk factors, late preterm, IUGR, SGA, LGA, these are all babies that are more likely to be admitted. But the number of babies who had hypoglycemia, as defined as 2 blood glucoses under 2.6, in the placebo group was about twice as much as in the dextrose gel group. The dextrose gel works, and when you look at babies who were admitted solely for a diagnosis of hypoglycemia, there was a statistically significant reduction with the use of dextrose gels in admission for hypoglycemia, 14% versus 25%. As a bonus, there was a lot less formula used at 2 weeks of age in babies who were exposed to the dextrose gel, probably because there was less maternal separation, because babies stayed with their moms who had the dextrose gel. It's worth noting, excuse me, that if you go across the country, in particular out in BC, if there's anyone listening from BC, you may know already that there's a resistance to using glucose gels. As mentioned, the glucose gels were designed for use in adults. The glucose gel used in the Sugar Baby study was locally made and designed for the neonate. When you look at Dr. Solomano's work, who's done some work with dextrose gels, he was able to demonstrate in commercially available dextrose gels, whether it was Instaglucose, which we use here in Winnipeg, or Dex4, that if you look at an individual tube or you look at variation between tubes, they're not exactly as labeled, depending on where you are in the top, middle, or bottom of the tube. Having said that, I don't have time to show you the data, but since we've started using dextrose gels here in Winnipeg, we have seen our admissions for hypoglycemia drop. So we use them without concern, but I know that there are some concerns with the use of these products elsewhere in Canada. I mentioned at the beginning the fast prior to discharge. The reason for the fast prior to discharge is babies who have persistent hypoglycemia past day 3. And in particular, if they have a known reason, if they're found to be hyperinsulinemic, there's always the fear that these infants may go home and have a parent that sleeps in, misses a feed. So for that reason, given that babies feed every 3 to 4 hours, we make a recommendation while they're still in hospital that they should be fasted from 5 to 6 hours and have blood sugars checked just prior to 3 hours, 4 hours, 5 hours, and 6 hours. And make sure that the blood sugar is maintained at greater than or equal to 3.3 so that they're safe to go home. Again, won't go through this entire slide, but I will just draw your attention to the middle part of the slide. And you can read this. This is taken directly from the CPS statement. In essence, we have two different paths. We have one path for the baby who's symptomatic on the left, or who cannot be fed, and then a path on the right for well infants who can feed or are at risk of hypoglycemia. The part in the middle has to do with the issue around glucose gels. One can either give glucose gel, or you can give a measured volume of feed, whether it's donor breast milk or formula or mother's milk. And the important things that I will just highlight in here are the importance of feeding early, the importance of checking for a response 30 minutes after a feed. And then as we move on to the second page, I would just point out that there is some very useful information in the footnotes, which makes recommendations around how best to manage different conditions and what to offer in terms of feeding supplements. So finally, one question that I think people may ask is, the CPS creates these guidelines. Do they need to be followed? So the short answer, strictly speaking, I think is no. However, many will recommend that they be taken almost verbatim and put into guidelines. My understanding, having looked into this before, is that local hospitals can set their practice, and they're free. Everyone is free to evaluate the evidence. I think I've shared with you, and in particular, focusing on the PES statement, that there is variation in recommendations. There's variation in the quality of recommendations. There's variation in the literature. And so if a local hospital wants to do something else, an example would be not use glucose gel, you're free to do so. However, the caution that I always make to colleagues who want to deviate significantly from the CPS statement, in particular, the center that is using or has used glucose levels under 2 as being their point of action, that if you do wish to deviate from what is being nationally recommended, you better have good evidence to back that variation. So in conclusion, normal preterm and term infants experience a rise in blood glucose between 48 to 72 hours. There's a real importance to balance identification of true persistent hypoglycemia and avoiding excessive testing by separating those thresholds for normal and also when you would investigate. And that's speaking to the 3.3 versus the 2.8 for investigation. And then finally, I think all units that have problems with babies with persistent hypoglycemia should be doing that monitored fast prior to discharge, just as a means of promoting safety. Thank you very much.
Thank you very much, Dr. Narvey. That was very informative and somewhat confusing. There's no doubt there's been some challenges and continues to be challenges in this guideline. I'd like to remind everyone who's interested to send in or to submit their questions in the Q&A button. We have quite a few questions already, which are great, and we'll do our best to get to them at the end of this presentation. I'd like to now welcome Joe Miller as he tells us how the case study story turned out, what prompted the family to seek legal advice, and with some comments and questions about his approach to the case from the plaintiff's lawyer perspective. I've welcomed Joe, and I'd like to just ask you to respond to one question before you start into your presentation. And that is, what is, from the legal perspective, what are your follow-up comments to Dr. Narvey's second to last slide about the obligation, for lack of a better word, to follow guidelines and recommendations?
First of all, thanks very much for inviting me to this, Chris. And Dr. Narvey, that was a fantastic presentation, and I can say I understood, I'm guessing 75 to 80%. So that's pretty good.
That's what I was hoping for. Thank you.
So basically, the issue that comes up from time to time in lawsuits is where a physician or a nurse does not follow the standard of care of the SOGC, or in this case, the Canadian Pediatric Society. And the issue becomes whether that in itself constitutes evidence of a breach of a standard of care. And I note in the in the presentation, Dr. Narvey, that you indicated that, of course, hospitals or health authorities have the right to examine the evidence and to make their own conclusions. But it seems that it's reinventing the wheel. It's not like you prepared the, I was going to say guidelines, but it's a position statement, over the weekend. This was a long process, looking at a lot of literature and consulting with a lot of experts. Surely I would think that a hospital or a health authority that chooses to deviate must have very good grounds to do so. Otherwise, it would certainly be evidence of a breach of the standard of care. That's from a plaintiff's counsel point of view. Do you have any comment on that?
You know what, I think, I hear what you're saying. I am not a lawyer, although I should disclose I'm the son of a lawyer and the son-in-law of a lawyer. However, I think that while there is, as you pointed out, a tremendous amount of review that went into the production of this statement, there is room, which I think I've acknowledged, to point out that some of the evidence may be flawed. So I think that if someone wants to deviate a little bit, that might be okay, depending on what the deviation is and whether they can provide data to support that there's a reason for it. And, I'll give you an example. I mean, the whole business of glucose gels. Initially, when we look at the algorithm that I showed you at the end, the flow diagram, there was no measured feeding volume in there initially. It was all about glucose gel. When we indicated it was time, we recommended glucose gel. And the feedback we received was a lot of pushback from one center in particular that did not want to use glucose gels. And so, interestingly, the approach, and maybe this is the best approach, is during the formative time, deal with it, not afterwards. So they chose to address us before we published it and make sure their concerns were put into the guideline, rather than just deviate from the guideline. Yeah, I mean, I guess my ego would like to say, of course, after I spent 4 years of my life on this, that people would just say, fine, we'll adopt it. But I think that from time to time, especially when things are controversial, as long as your center can quote evidence to support its position, and it's not a huge departure, I think you're probably in an okay stead. And the last thing I'll just mention, Joe, sorry to take up so much time on this, is I do have significant concerns about the center using under 2, as a threshold. I think they're, and I've shared that with that person, that I think they're flirting with danger.
Okay, and I think the follow-up to that, at least from a legal point of view, and understanding that that's what plaintiff's lawyers at least try to do, is the role of informed consent for the parent. So if you have a hospital that chooses to only treat at 2.0 as opposed to 2.6, the question arises as to whether the parent should be advised that the hospital policy, in fact, is contrary to what has been recommended by the Canadian Pediatric Society. So that's another issue that may come up in the legal arena.
So, were you wanting to comment on with a consent? You see, that's interesting. I can tell you, I wear 2 hats, or 3 hats, maybe even 4. But one of the hats I wear, of course, is chair of the Fetus and Newborn Committee, in addition to writing the statement. And so I feel responsible for the content coming out. On the other hand, I'm also the section head of neonatology here in Winnipeg. And I can tell you that there are some practices that we have here that are not in line with the CPS. And that puts me in an interesting position where my colleagues that don't necessarily want to adopt everything that we've put out in a statement. We do not, as a matter of practice where we deviate, we don't draw the attention of that to the patients we care for. We don't disclose it. Having said that, I don't think that our departures are major departures. I think if you were going to do a major departure, it's interesting. I think it comes down to your perception of risk. If you believe strongly and you have literature that the CPS is wrong, and really wrong, in their conclusion about 2.6, should you be obligated to disclose that you are different? I actually don't know. What would you say?
I would say, from a plaintiff's point of view, I would say absolutely. And I think there's case that indicates that if another physician perhaps has a different idea of what would be the best treatment, the patient is entitled to know that, and so as to allow the patient to actually be the one to make the decision. And I think you're right that it comes down to the degree of difference between the guidelines and what is actually happening. That's just another thing to flag, that we have to keep in mind the possibility of an argument of a breach of informed consent if there's a deviation from the position statement of the CPS. So, Chris, should I run through how this file came to us to begin with?
Yep. Let's hear the end of the story, Joe.
Okay, thank you. So this birth, the actual birth, not the hypothetical birth, actually occurred in March of 1999. And that timing is significant because at that time in Alberta, there was a 2-year limitation period to sue, even for injuries to children. And I remember this case specifically because the parents contacted us a few days before the expiry of the 2-year limitation. So what we knew was it was obviously a brain injury. It obviously happened either at labor and delivery or in the neonatal period, but we had no more information than that. And so basically what happened was we needed to issue a claim. We knew who the prenatal doctor was and the labor and delivery doctor, so we could name them as a defendant. We knew where the birth occurred, so we named the health authority. The claim was filed, and then once the claim is filed, it gives us a certain period of time to investigate the circumstances and to come up with a theory of the case. So I should indicate that this did involve a very significant injury. And it became more apparent, obviously, as time went on, that this child had very significant cognitive impairments, had an IQ of around 60. Both of his parents were professionals. There were significant behavioral issues, issues with fine motor skills. And he would never be employable. He would never be able to live independently without support. So it was a very significant injury. So we filed the claim, and then that gave us a year to investigate. And the way that we investigate claims at our office, at least, is we start off by trying to figure out causation. We're trying to figure out what caused the brain injury and when that insult occurred. And so in looking at this case, and starting with causation, a number of things jump out. First of all, that this was an IUGR, or a small for gestational age baby. We're looking at the fundal measurements that are lagging significantly behind at 42 weeks. You get a fundal measurement of 34 centimeters, which is huge. We have a low birth weight. And we also, on the other hand, have a very significant maternal weight gain. So let's assume for a moment that I decide, okay, that's a factor we got to look at, and I'm going to have a neonatologist take a look at it, and I send it out to Dr. Narvey, and I say, Dr. Narvey, what's the significance of SGA or IUGR? That's the first question on that point. And why in the guidelines are both of them listed? Because there's overlap, I presume, between SGA and IUGR babies. I'm throwing the football to you.
Okay. I wasn't sure where to jump in. So yes, there is overlap. So SGA is a baby that is under the 5th or 10th percentile, depending on curves that you use. The way to think about intrauterine growth restriction, and this is the way I teach medical students, so I'll teach this group today, is that when we're looking at intrauterine growth restriction, you may be appropriate for gestational age, but have IUGR, and you can be small for gestational age and have IUGR. How is this possible? Okay, so the way it's possible is intrauterine growth restriction means that the baby started to experience a deceleration of growth. Depending on when it happens, let's say it's due to placental failure. Let's say mom has late maternal hypertension and the placenta starts to fail. You might have a baby with a birth weight, let's say, of 2.9 kilos, which wouldn't be significantly small. But the reality is they were destined to be 4 kilos. Okay, they were on track when you were plotting their symphysis fundal heights, or they were on track to be about a 4 kilo baby. They've slowed down, they decelerated. So that baby would be AGA, but would be IUGR. Why would they be IUGR? It would be because, well, one, we know that they fell off their growth trajectory. But secondly, and it was in this case too, what you typically see in those cases is an asymmetrical pattern of growth restriction, meaning that the head is relatively spared. So you get a normal head circumference, let's say I think this one was 70th or 80th percentile, 34 centimeters. And then you get a length, which is going to be normal, which in this one case, I think was 90 percentile. But then you get a weight that is significantly lagging behind. So even though the baby could be AGA, they're still IUGR. Now the SGA baby means that by birth weight, they're small. They're less than the 5th percentile. So you can have overlap there. Regardless, the pattern you're always looking for that is the big alarm bell is the asymmetrical growth restriction. And the reason that you look out for it is because the reason it's a risk factor is because what the body does in the setting of deprivation of blood flow and oxygen, what the body does is the body's smart. The body preserves blood flow to the 2 organs that need to keep it alive. And the 2 organs are your brain and your heart. So the reason the brain grows and is normal in size is because the body is diverting blood supply to the brain. It's taking away from the bowels, it's taking away from the kidneys, it's taking away from the muscles, from the liver. And the reason I mentioned liver last is because what's stored in the liver is glycogen. Glycogen is stored sugar. And what we know is up to 36 weeks, the amount of stored glycogen in the liver is really little. Between 36 and 40 weeks, it normally spikes. And then after 40 weeks, in the first hour to 2 after birth, all that glycogen just gets burned and it falls away. And that's what the baby is living off of after the cord is clamped in order to maintain their blood sugar. Then they start to metabolize muscle and they start to use other resources like fat to keep their sugar up. Okay. And as their feeds come in, they start to get extra sources, but they rely for the first few hours on that stored glycogen. So when you're growth restricted and you've been diverting all that blood supply to your brain and your heart, you never get that stored glycogen. And so when you clamp that cord, they're starting in a deficit. They have nothing to fall back on. And so if you don't feed in the first 2 hours, they have nothing to burn. And so that's why, sorry, it's a long explanation, but that's why SGA and that's why IUGR are independent, but also linked risk factors.
And with SGA or IUGR, that would put the baby in the at-risk category.
Correct.
And once in the at-risk category, when should the first blood glucose be taken?
In an asymptomatic baby, by 2 hours of age. And that's why we recommend that they feed first.
When you say by 2 hours, does that mean anything within the 2 hour period?
Generally 2 hours, yeah. Because again, I mentioned the reference, well, I didn't tell you the reference, but we know in a sample of well babies that were sampled every 30 minutes from birth for the first couple of hours, you can get down and it can be normal, the fifth percentile, 1.8 at 1 hour in totally well babies. So yeah, at 2 hours of age, we check a sugar unless they're symptomatic. If they're breathing fast, if they're jittery, if they're having lethargy, or they're irritable, you would check a sugar before that.
Chris, I want to put you on the spot here. Let's say it's a IUGR baby, so an at-risk baby. How would the neonatal people, the nursery people, know that? And is it the nursing decision to do the first blood glucose?
Well, I think in this particular case, this is a long, skinny baby. This is a scrawny kid. And the neonatal nurses would have access to the antepartum history, the prenatal records, the fact that the symphysis fundal height was disproportionate to the gestational age, to the operative record where the physician said that one of the indications for C-section was suggested small for gestational age. So it's, the expected nursing knowledge is that, all babies are weighed and measured, head, abdomen, length, weight at birth, and there's very clear guidelines. But I'm really interested in Dr. Narvey's comment that you can be AGA but IUGR at the same time, and I think that's actually what this baby was. Yes, nurses, most hospital policies have direction for nurses to independently perform that initial glucose. You don't need a physician's order to do so if the baby's either symptomatic or falls in the high-risk category. And in this particular case, which I reviewed for you, Joe, some time ago, it was very interesting that the hospital, to the indications for measuring, early measurement of glucose in infants and identifying infants at risk for hypoglycemia, was intrauterine growth restriction regardless of fetal weight. And I thought that was so interesting because that leaves up some room for clinical judgment. And that is, like I said, this is a long, skinny kid. And the other indication in this particular case was babies who develop feeding problems. So my opinion of this case was twofold in that, and there was no blood glucose done at birth based on presenting conditions, but there certainly were indications that that IUGR, or fetal growth restriction, had occurred, whatever it was called at the time. And then this baby came out of the gate pretty strong with breastfeeding, but just petered out over the next 48 hours, which isn't uncommon for a variety of reasons. So yes, nurses, anybody working in certainly doing perinatal care should have that base knowledge of which babies are at risk. Hospital policies also guide nursing knowledge guides. And it was my opinion that this baby should have been very carefully tested, very aggressively fed, and especially more so over time. It's interesting, and this is not in contradiction, but a little bit different from what Dr. Narvey is describing, is that you check early and then watch. I wonder if this early glucose would have been normal or somewhat normal, but the feeding problems developed in the first 48 hours.
Chris, I would also just add to that, because I remembered that this case was from 99, and you can't apply, not criticizing either of you, but you can't apply current recommendations to previous recommendations. So back in 99, I was in practice back then, very early, but we were checking almost routinely at-risk babies at 20 to 30 minutes of age. And so I presume, even though that was in Manitoba, that it probably back then was not too dissimilar in Alberta. So I agree with you completely. There was a failure in this case to check an at-risk baby.
I was also in practice in 99, and we checked quite early, but I think the threshold at the time was 2.0. So, that's changed with this new guideline for sure.
Yeah.
Mm-hmm.
Now, doctor, I want to touch upon one of the other risk factors that is listed in the position statement, and that is perinatal asphyxia. So in this case, we have, to some extent, a concerning fetal heart tracing, decreased variability, variable D cells, late D cells. There is a finding of meconium. On the other hand, the cord gases were fine, the scalp gas was fine, the apgars were fine. There was no cooling done. Wouldn't have been done in 99.
Right.
It would have been. And no obvious seizure activity within the first 24 hours. So we don't have, I don't think, evidence that if there was asphyxia, it actually resulted in hypoxic ischemic brain injury. But we do have a concerning tracing, and we do have a meconium. So the question I have is whether that would fit within the perinatal asphyxia at-risk category in the position statement.
Yeah, I don't think it would. And I realize, having asked that question, that, you know, we don't define it specifically in the statement, which is why you're asking the question. We certainly see, you know, roughly 1 in 10, I think, pregnancies can be complicated by meconium. So meconium is common, but asphyxia is not. We do know, that hypoxia causes internal sphincter relaxation, which is what leads to the passage of meconium, and certainly the tracing being poor would go with that. I think I can't speak for guidelines across Canada, but what I could say is I think if it was just meconium, even in the presence of a poor tracing, if the baby's apgars were good, the cord gas was good, the scalp gas was good, the clinical exam was normal, I don't think that would trigger a glucose check in many places. Because I was going to add one thing that I recall from my days in Alberta, was there was a maternal risk sheet, which I presume the nurses rely on quite a bit, where they would put down excessive, there'd be tick boxes for excessive weight gain, fetal deceleration, and these screening tools are used to activate having the newborn response team, present for these deliveries. It would not surprise me, even though it's not official, that in many of these cases, if a newborn response nurse saw all these risks, they might suggest a sugar get checked, but I don't think it's part of a standard protocol.
Chris, do you have input on that?
I would agree with that it may not be part of the standard protocol, but I would just leave a little wiggle room for clinical judgment in this particular case, based on how this baby just would have presented, 90th percentile in the length and 5th percentile in weight. And but I think in this case, the point was more like over time, the risk factors compounded. There was the pre-existing, the antenatal risk factors, the birth, the interpartum risk factors, but then we had that growing risk factor of poor feeding. And, when you look at the last 24 hours before this infant was admitted to the NICU, there's really only one breastfeeding that's noted to have gone well, and approximately 2 ounces or less than 3 ounces of infant formula that was given in the 24 hours prior to admission. And there was a 7-hour period prior to the time that the baby went pale. And the pediatrician was called that there was no evidence that the baby had fed anything at all, no formula and no breast. So I forget where I was going with that, but
we were discussing the risks, and whether the asphyxia alone. And I guess I was just going to say, I agree with everything, Chris, you just said. And this baby, again, would have qualified for screening based on the IUGR. I think the asphyxia, I don't want to call it asphyxia, but the perinatal distress that was on top of it, I think, as you say, was additive, but in and of itself, there was a failure to screen a baby who was at risk.
Sure. And the asphyxia, I think, also based on the normal scalp pH and the normal cord gases and the presentation of the baby at birth and described as active and pink and crying and an APGAR at 9 at 5 minutes. I don't think it would have been a matter of routine other than looking at the, asymmetric IUGR. I hate to rush you, Joe, but we're at 11:20. So if you've got a couple more questions that are burning, let's go for them, or a wrap up on the case. There's lots of questions in the chat box, and I'd like to have an opportunity to get those through. So do you have another comment or question that you'd like to put forward?
One more question.
Okay.
And that is, as a plaintiff lawyer, we relied very heavily on imaging and the results of the imaging, particularly in hypoxic ischemic cases. What is the practice in relation to imaging in the context of what might appear to be a hypoglycemic brain injury?
I'll try to be brief, given that we have questions. So over time, it's changed. In the early 2000s, there was a lot of literature coming out on occipital and parietal lobe injuries related to hypoglycemia. People were doing MRIs left, right, and center. And then there was some data showing that by 6 months of age, you couldn't see those anymore. So they kind of fell away as part of the standard workup. If there was a seizure with hypoglycemia, there would be an MRI done. But the other thing I would just mention is IUGR, SGA, asphyxia, they all seem to go hand in hand. They often are comorbidities together. And with that, you're more likely to get the MRI after 3 days, after the warming period is over, for HIE. And the problem, as my research has revealed, is the HIE damage overshadows, any injury from hypoglycemia. So I would say it's no longer standard of care to do imaging for just hypoglycemia, but it is standard of care to do it if there's any evidence of neurological injury.
Well, thank you very much, Joe. I wish we had... Oh, sorry. Thank you very much, Joe. I wish we had more time to talk this through, because I know that this topic and the medical legal crossover is of great interest to everybody. So thank you so much. If you've got questions for Joe, please put them in the Q&A box. But we do have a couple questions from the audience that I just want to go through a couple of them. I think some of them got answered as both of you spoke. But one of them, for you, Dr. Narvey, is there any reason why a high pregnancy BMI at this point is not considered a risk? Someone has said we see anecdotally that babies present as jittery and hypoglycemia when the only risk factor for that particular pregnancy is elevated BMI.
Short answer is I don't know. I think probably at some point we should look at that, because I know in my own practice, when I find absolutely no reason for a baby to be hypoglycemic, if I see there's an elevated BMI, the comment from myself and my colleagues is usually, you know what, they probably did have diabetes. They probably just at 28 weeks when they had that oral glucose tolerance test, they passed it, but at some point they developed, because you can't find any other explanations. So I think that's something to look at in the future.
Good answer. Good answer. Here's another question, talking about a way to try to minimize admission to NICUs. We're currently looking into offering breastfeeding plus formula at 2 to 5 mils per kilo before 2 hours of life as the first feeding to try and reduce our admissions to NICU and keep the dyad, the mother-baby dyad, together. We're trying to use this just as a bridge for when milk supply comes in. What are your and not use dextrose gel? Do you have any particular comment on this endeavor?
Well, it's a little bit of the devil you know and the devil you don't. We are really trying to encourage nationally exclusive breast milk diets. Trying to avoid, especially in the late preterms, trying to avoid exposure to formula. We know that formula does alter the microbiome, which can have later health. That's the bacterial populations in your colon, which can have long-term impacts on things like obesity, allergies, asthma. So on the one hand, you're trying to avoid the glucose gel. On the other hand, you're introducing something that maybe you don't need to introduce. I would sooner see you introducing donor breast milk if you had access to that, small volumes, so at least it's human milk. And again, I'm not, I should have stated up front, I don't have any shares in any companies that produce glucose gels. I just have had great experience with them. And our units have had great experience with them. But no, I think if you can avoid the formula, that's great. If you don't have access to a donor milk bank, supplementing with a little bit of formula seems reasonable if you're really trying to ensure that volume it gets in, and that's in our statement.
Good, thank you. A comment here, this one's kind of interesting, and it's maybe for both of you, where there was an incident where a mother was refusing to monitor glucose in a small for gestational age infant. The hospital staff, I don't know if it's physician or nurses, contacted local child protection. And the question posed to the medical staff was, is this child at imminent risk? And we weren't able to answer necessarily based on on the data that they had. Do either of you, I guess I have one of my own questions I'd like to interject in here. What are the barriers to, because I'm assuming there's many, I heard you answer or say the words unnecessary poking babies and heels that become damaged. What are the barriers for parents and doctors and nurses to recommending blood glucose testing or accepting it, as this particular case was? And Joe, if you have any comments on the legal side of this, although I realize this isn't your wheelhouse necessarily, open to both of you.
I guess the only thing I would say is, if it's an at-risk baby and the mother was absolutely refusing to let us test the sugar, then you're treating blind. I think you would need to have something in writing from the mother that she is going against standard medical advice. I'm sure the lawyers in our hospital would jump all over this, or with Shared Health, and get us to have her sign something. I don't know. I don't know how far it would go, whether child protection would be brought in. I mean, it really depends. I mean, if this was an extremely growth restricted infant, that you know that your index of suspicion is almost certainly the blood sugar is going to be really low, and could injure this child, and you have no idea how to manage the baby, I actually could see giving child protection a call, in that case. If it was a borderline, I think you might just push a lot of food, run an IV just in case. Although if she didn't want the poking, she probably doesn't want an IV. I mean, it's a very difficult thing to work out in a couple minutes, I think. But Joe, I don't know what you would say.
Well, it's a very tough situation, but I guess the starting point is that she does have the right to take that position in the first instance. Now, whether the child protection or whether the courts would go over her rights to do that, I don't know. But I guess my question back is, let's assume for the moment that she opposes the blood testing, but not treatment. And I understand you're flying blind, but would the lesser of the evils then be to give some dextrose gel or D10W in a situation where you're quite sure that the baby would likely have low blood sugars?
Yeah, I mean, I hear your point. I think the problem would be how often, how much, and there's also potential complications from hyperglycemia. We know that can affect the eyes. We know that can cause cerebral hemorrhages. So, yeah, I mean, it's a tough, it's a tough one.
It's a tough one. So many situations in the labor and delivery or perinatal setting are tough. The social situations are tough. Let's go for one more question here, and then we'll wrap this up. But this is a great question, I believe. This is for you, Dr. Narvey. You mentioned that diazoxide is used to treat hypoglycemia in neonates, and this person has said, or I think that's the drug you mentioned. In the clinical setting, is this drug given in combination with thiazide diuretics to block or reduce glucose-stimulated insulin secretion and further increase blood sugars? Or would this compounded treatment option be considered too aggressive for a neonate?
Sorry, I just answered quickly. Another question about twins in the chat there, because I realize we won't have time. We are giving diazoxide as in combination with thiazide diuretics as they are recommending. The diazoxide does antagonize insulin, and often we find these babies are hyperinsulinemic. We did a study here actually looking at all of our cases, all of our consults for persistent hypoglycemia, and 51 out of 55, this is published actually, 51 out of 55 were due to hyperinsulinemia. So that is by far and away the most common diagnosis. The problem with diazoxide is it does cause fluid retention and can lead to pulmonary hypertension. So we do start diuretics at the same time. So well thought out. Yeah.
Thank you. Good answer. Well, there's more questions, but we are out of time. We'll try to answer the questions that you have. I'll see if Joe or Dr. Narvey can give us a response to anything outstanding. But I want to thank everyone so much for attending today, and a huge thank you to our presenters, Dr. Michael Narvey and Joe Miller, for the very generous sharing of their time and their knowledge. I hope you found this webinar both engaging and informative. I'm happy to hear your ideas for future webinars if you have them. For more medical legal learning, we do have an excellent webinar on the updated SOG guidelines for fetal health surveillance and fetal monitoring. It's available through our website on connectmlx.com. That webinar has been picked up for teaching residents and nursing students and new staff orientation at hospitals across the country. And we're really happy to support continuing education everywhere. You can also check out our podcast, Inside Medical Malpractice. It's available on Apple, Spotify, Google, YouTube, and through our website as well. The podcast is doing very well, and there's an exciting round of new guests coming up. Just being released this week is my second interview with nurse lawyer Farah Ismail, as she talks about the troubles that have plagued the Ontario long-term care system over the past few years, which include a nurse serial killer and the COVID-19 seemingly never-ending pandemic, which has caused all kinds of problems. We'd love it if you'd listen and subscribe. And as with the webinars, you are more than likely able to claim continuing education hours for that podcast. So check it out. Once again, thanks to everyone who's attended. Thanks to our speakers. I hope that wherever you are today, it's a lovely spring-ish day and there's something enjoyable ahead of you. So take good care and goodbye.